Everyone to the PW Method, Dr. Patil here, and we are continuing our series on Reed Harris. And today we are taking a topic which is about myasthenia gravis, and all of us understand that myasthenia gravis is a very commonly tested topic in our entrance exams as well as in our theory and bedside discussions. So what I will do today is, it's a vast topic, but I'll try to dissect the key points from Harrison in a question and answer simple format. Okay, so let us begin first by understanding what do you mean by myasthenia gravis, right? So can we make an attempt to define myasthenia gravis? All of us have a rough idea about what is it, right? So can anybody make an attempt to define what is it? So guys, please remember, myasthenia gravis is a autoimmune disorder. Why am I calling it as autoimmune disorder? Because it is a condition where, good evening, Nusaiba. It's a condition where antibodies are formed against the acetylcholine receptors in the neuromuscular junction, right? So that's why, because it is an antibody mediated disorder, I will call it as an autoimmune disorder. So myasthenia gravis is an autoimmune disorder of what structure in the neurology it is affecting. For us to be able to do an effective muscle contraction, what are the essential structures? We need the muscle, neuromuscular junction, the lower motor neuron in the peripheral nerve, then the upper motor neuron in the spinal cord, brainstem, subcortex, and cortex. So if all of them are maintaining their integrity and functional normalcy, we will be able to contract the muscle. Anyone disturbed, we end up developing weakness of the muscles. Now, where should I place this myasthenia gravis? Yes, it is a disorder of neuromuscular junction. It is a disorder of neuromuscular junction. Now, neuromuscular junction disorders can be classified as presynaptic disorders and postsynaptic disorders. Now, what do I mean by presynaptic and postsynaptic? When we look at the neuromuscular junction anatomy, it has two components mainly, right? One is a presynaptic nerve terminal, a neuron, right? And on the other end of it, we have a muscle. So if a disease which is affecting the muscle side of it, then we will call it as postsynaptic. And a disease which is affecting the nerve side of the neuromuscular junction, we will call it as presynaptic. So now myasthenia gravis is a postsynaptic neuromuscular junction disorder. So this is a postsynaptic affecting postsynaptic membrane. Postsynaptic membrane. Nusaiba, absolutely right. So can anybody give me an example for a neuromuscular junction disorder which is affecting the presynaptic terminal and not the postsynaptic membrane? The answer for that is Lambert-Eaton myasthenic syndrome, and also very famous from your forensic medicine, that is botulism. So botulism and the Lambert-Eaton myasthenic syndrome, they predominantly cause presynaptic dysfunction. Myasthenia gravis is a postsynaptic dysfunction. Okay. Now, being an autoimmune disorder, it also means that we probably don't know much about its etiology, because most autoimmune disorders, we don't have clarity about the etiology. Same kind of applies to myasthenia gravis also. But by observation over decades, we have learned some essential pointers which suggest that, okay, if you are of this gender, if you are of this age, you are at higher risk of developing the myasthenia gravis. So let us look into the epidemiology. Myasthenia gravis is the most common disorder of neuromuscular junction. Whatever other disorders you know, like Lambert-Eaton myasthenic syndrome or the botulism, they're all relatively rare. So MG is the most common disorder of neuromuscular junction. Now you should tell me whether males are more prone to develop myasthenia gravis or the females. I will give you the clue. The clue is, this is an autoimmune disorders. Generally, autoimmune disorders are common in which gender? I'll give you further clues. Think about Hashimoto's thyroiditis. Think about Graves' disease. Think about SLE. Think about rheumatoid arthritis. All these are autoimmune disorders, right? Yes. So typically, autoimmune disorders are more common in females, and same rule applies to even myasthenia gravis. So in terms of gender, myasthenia gravis is way more common than in females than males. Nusaiba, Pratyusha, absolutely right. But please remember, it doesn't mean that males are not affected. Males can also get affected. And when we look at the nature of involvement, means what age group typically females get affected and what age group typically males get affected, one thing becomes very clear. Most of the autoimmune disorders that you know that occur in females, right? Hashimoto's thyroiditis, Graves, SLE, they typically affect that middle age, right? The reproductive age group that we talk about. And that applies to myasthenia gravis also. So this is typically more common to present in the reproductive age group or between 20 to 30 years in females. In females. Those who don't know, this is a symbol of female gender. In males, this typically occurs in the age range of 50 to 60 years. 50 to 60 years, we see another spike in the incidence, and most cases reported in this age group are going to be males. Now, I have one question. A young female developing myasthenia gravis versus an old male developing myasthenia gravis. Who carries the worst prognosis? Is it a female who is likely to carry a worse prognosis, or is it a male who is likely to carry worse prognosis? And this is something pretty basic. The same principle you can apply to many other autoimmune disorders. So that way I can say, if you get a young female, typical case of SLE versus an elderly male or a male getting SLE, who carries worse prognosis? Pratyusha, absolutely right, spot on. So all these disorders they are typically disorders of females. If they occur in males, that means something much more sinister or wrong should be there for it to occur in males, and thus it carries poor prognosis. Just to give you an example, carcinoma of the breast, quite common in females, but if it occurs in male, it carries worse prognosis. So similarly, if a male develops myasthenia gravis, especially in the elderly age range, he carries poor prognosis. On the other hand, a young female developing myasthenia gravis might have much better prognosis than an elderly male. Okay, so these are the few epidemiological points you need to remember. Point number one, it is the most common disorder of the neuromuscular junction, typically more common in females than males. And age-wise, it is the young females and elderly males who are prone, and an elderly male developing myasthenia gravis carries poor prognosis. Sudhapa, there are several mechanisms. For individual autoimmune disorders, there are individual mechanisms. With respect to myasthenia gravis, we haven't understood much why young females are more prone and elderly males are more prone. With respect to SLE, there is sufficient evidence to say that estrogen does play an important role. Okay. Now, coming to how do we classify myasthenia gravis? You will come across two ways of classifying myasthenia gravis. In one, it is depending on the extent of involvement. You can classify myasthenia gravis as generalized myasthenia gravis or ocular myasthenia gravis. Ocular myasthenia gravis is only eye muscles are involved. Generalized myasthenia gravis, in addition to eye muscles, the other muscles are involved. That classification we will look at later. Primarily now we will look at the etiological classification. So myasthenia gravis is classified into four groups: the acquired autoimmune, transient neonatal myasthenia gravis, congenital myasthenic syndrome, and drug-induced. Okay. So among these, the most common one is the acquired autoimmune. So basically, it's an autoimmune disorder that you acquire. You are not inherited with this disorder, and that is the most common. Okay. This is what we will be discussing in detail, but we have this type called as transient neonatal myasthenia gravis. Now, as the name says, transient means this is not a permanent disorder. The neonate who has this kind of myasthenia gravis is not going to live his entire life with myasthenia gravis. It stays there for few weeks to few months and then recovers. Why this is happening? This is due to transplacental spread, transplacental transfer of antibodies. So basically, if mother has myasthenia gravis, she can transfer those antibodies to the newborn, and because those antibodies are there in the newborn, he may show signs and symptoms of myasthenia gravis, but those antibodies will be eventually destroyed by the body. No more new antibodies will be formed and the patient will recover. That is why we call it as transient neonatal myasthenia gravis. Okay. Then we also have another type of myasthenia gravis, which is called as congenital myasthenic syndrome, or CMS. It stands for congenital myasthenic syndrome. Okay, now in these patients, there is no antibody as such. This is not a pure autoimmune disorder, but otherwise the disease behavior is similar to myasthenia gravis. And what is the defect here? These patients have inherited mutations that result in abnormal acetylcholine receptors. So they have mutations affecting acetylcholine receptors. So it is not an antibody which is blocking the receptor. Receptor itself is dysfunctional, right? So you're born with a dysfunctional receptor. No matter how much acetylcholine is produced by your presynaptic terminal, your muscle is not going to respond. Such conditions we call it as congenital myasthenic syndrome. Okay. Then certain drugs can impair the functioning of the neuromuscular junction, and such cases we call it as drug induced. Now, one of the common MCQs is like, which of the following is known to cause drug induced myasthenia gravis? Another MCQ is, which of the following drug is contraindicated in a patient with myasthenia gravis? Right? Answer for both of that would be the drugs which are known to cause myasthenia gravis. I've made a small table comparing it. So I will come there. D-penicillamine. This is the single most important drug that you need to remember because this is examiner's favorite. Most of the questions about drug-induced myasthenia gravis are centered around D-penicillamine. Apart from that, curare and curare derivatives like atracurium, vecuronium, aminophylline, quinine, procainamide, and calcium channel blockers. So one thing, another important thing that you need to remember is calcium channel blockers, because see, all these drugs are not very commonly used in day-to-day practice. Aminophylline, we no longer use it, right? Curare, certain anesthetist might use it for anesthesia purpose, so selective use. D-penicillamine, being a chelating agent, you use it only in selected conditions. Quinine may be for treatment of malaria in pregnancy, otherwise we have better drugs. Procainamide, again, selective cases as an antiarrhythmic. But calcium channel blockers are pretty commonly used, right, as antihypertensives, vasodilators for vasoconstrictive disorders. So this is something that is strictly contraindicated in a patient with myasthenia gravis, and you should always remember that because it figures in MCQ. Okay. So summarizing again the classification, myasthenia gravis can be classified into 4 groups. Acquired autoimmune, where it's an autoimmune disorder where you acquire it to develop antibodies against acetylcholine receptors. That is the most common, accounting for more than 90% of the cases. Then transient neonatal myasthenia gravis is where the neonates or newborns born to a mother with myasthenia gravis, they have received antibodies from the mother because the antibodies could pass through the placenta. Now that these antibodies produced in the mother's body have entered the neonate, they will cause the symptoms in the newborn. But newborn's body is not producing any more antibodies. The baby does not have the autoimmune disorder. So whatever antibodies it has inherited from the mother, they have their half-life. So over time they will be destroyed, and after that patient will make a complete recovery. So such condition is what we call as transient neonatal myasthenia gravis. If you have a receptor mutation in acetylcholine receptor, we call it as congenital myasthenic syndrome, and certain drugs are also known to cause. Okay. Now we have a fair idea about what is myasthenia gravis. We'll try to understand it a little better by understanding its pathophysiology. So our focus is more on the autoimmune type of myasthenia gravis, which is the most common. So obviously there are antibodies. In terms of antibodies, they will ask you what is the most common antibody that we see in patients with myasthenia gravis. The most common antibody seen in patients with myasthenia gravis, which accounts for more than 85% of autoimmune myasthenia gravis cases, is anti-acetylcholine receptor antibody. Okay, but that's not the only antibody. Some patients may have other antibodies. What are those other antibodies? The second most common antibody that is seen in around 5% of the patients is going to be anti-muscle specific kinase. Anti-muscle specific kinase antibody. Okay. Apart from that, we have also a third common antibody, which right now you can also call it as least common. Third most common is the least common, and that is usually seen in around 2% of the cases, and remaining patients we don't find any antibody. So this antibody is called as anti-lipoprotein 4 receptor antibody. Anti-lipoprotein 4 receptor antibody. Pratyusha, spot on. Very good. Very good. These 3 antibodies you need to remember. MCQ में क्या पूछेंगे आपको? First thing they will ask you is what is the most common. Most common तो anti acetylcholine receptor antibody है. उसके अलावा 2 और हैं, anti muscle specific kinase MuSK antibody and anti lipoprotein 4 receptor antibody. Okay, so let me focus on the anti acetylcholine receptor antibody, and disease को थोड़ा सा डिटेल में समझने के लिए we will go back to physiology and understand the neuromuscular junction physiology. Okay, so let me say that I want to flex my biceps. मुझे biceps flex करने के लिए I have to send the signals through musculocutaneous nerve to my biceps. शुरू कहाँ से होगा impulse? मेरा motor cortex, right? Motor cortex in the brain. Now from the motor cortex in the brain through upper motor neuron, the signal will reach the lower motor neuron in the C5 C6 segment of the spinal cord. From there the lower motor neuron will pick up the signal and transfer that signal through or via musculocutaneous nerve to my biceps. In the bicep, the signal will be handed over to the neuromuscular junction. Neuromuscular junction will communicate to the muscle and then we will contract the muscle. Now, the signal that was generated in the upper motor neuron, is it a chemical signal or is it an electrical impulse that I generated in the motor cortex of the brain? Is it a chemical signal or an electrical impulse? जो अपर मोटर न्यूरॉन मतलब कॉर्टेक्स, सब कॉर्टेक्स, ब्रेन स्टेम, स्पाइनल कॉर्ड से C5 C6 स्पाइनल सेगमेंट तक पहुंचा, and then the impulse that was handed over to lower motor neuron, is it a chemical impulse or a electrical impulse? So please remember, it is a electrical impulse. It's an electrical impulse. So we are primarily causing the depolarization of the membrane and sending an electrical impulse. But once that electrical impulse reaches the nerve terminal, unfortunately, we do not have the receptors for electrical impulse on the muscle. So this electrical impulse need to be converted to a chemical impulse because muscle to sirf chemical ke sunte hain. So the job of neuromuscular junction is converting an electrical impulse coming from the brain to a chemical impulse so that we can communicate to the muscle. Now, how do I convert this electrical impulse to chemical impulse? Okay, so let me tell you. From my lower motor neuron, I have received an electrical impulse. Okay, as the electrical impulse reaches the nerve terminal, in the nerve terminal we have specific gates. We call these gates as voltage gated calcium channel. Look at the name of the channels. They are called as voltage gated calcium channels. In the name, everything is there. First thing, it tells that it is a channel which allows the movement of calcium molecules, right? Then why are we calling it as voltage gated? Because it opens when the voltage of this membrane increases to a certain threshold. After that, it opens. So whenever I send a signal from my brain to the neuromuscular junction for a contraction of a particular muscle, what will happen to the voltage of this membrane? Increases. So जैसे ही voltage increase होगा, ये जो gates हैं वो खुल जाएंगे. These voltage gated calcium channels will open and they will allow the influx of calcium. They will allow the influx of calcium once the voltage gated calcium channels are open. जब calcium अंदर आएगा, so this calcium will facilitate rupturing of these vesicles. What these vesicles are containing? They are containing acetylcholine. These acetylcholine containing vesicles will be migrating to the presynaptic membrane, and once they migrate to the presynaptic membrane, they will rupture. And once they rupture, they will release the acetylcholine into the synaptic cleft. So now the impulse that I received was an electrical impulse. Now this electrical impulse is converted to a chemical impulse with the help of these voltage gated calcium channels. Now that I have released the acetylcholine, these acetylcholine molecules will go and bind its receptor. So whatever I have drawn here in black colors, think of them as acetylcholine receptors. Okay, I have one question here. What kind of acetylcholine receptors we have in the skeletal muscle neuromuscular junction? Is it nicotinic or muscarinic? Is it nicotinic or muscarinic? We have beautifully coupled an electrical impulse coming from the brain. We have converted it to a chemical impulse with the help of calcium and voltage gated calcium channels. Now we have released the chemical. The golden chemical here is acetylcholine. It is going to bind its receptors. And these receptors which we get in the skeletal muscle neuromuscular junction are going to be nicotinic type. These are nicotinic type of acetylcholine receptors. In your smooth muscles, you have muscarinic type of acetylcholine receptors. That is why when you have to treat asthma or COPD, you use anti-muscarinic agents, like long-acting anti-muscarinic agents, LAMAs. But in skeletal muscles, we have the nicotinic type of receptor. Good evening, Nilanjana, and right, all of you are right. We have nicotinic type of acetylcholine receptors. So once this antibody binds with the acetylcholine receptors, that will trigger a series of chemical cascades inside the muscle, and that will result in the muscle contraction. This will result in the muscle contraction. So effectively, we have coupled an electrical impulse, converted it to a chemical impulse, and resulted in muscle contraction. Okay. Now, point here is once I have released the acetylcholine, this acetylcholine should not continuously bind to the muscle. Otherwise, the muscle will remain contracted. It will not release. So this has to be taken off from the receptors. How will I clear it from the receptors? whatever acetylcholine that we have produced here will get converted to choline with the help of an enzyme called as acetylcholine esterase. Acetylcholine esterase will degrade acetylcholine to choline. The choline will not be able to bind to the receptors, and the story is over. The muscle will now relax. Okay. Now, what happens in myasthenia gravis? I create antibodies which are prone to bind to these acetylcholine receptors. Okay. And what kind of binding they do? They have this competitive inhibition. They are inhibiting antibodies. Antibodies binding, they do not stimulate, but rather they inhibit, and they are they are competitive inhibitors. They're competing with what? They're competing with acetylcholine. So now who wins the competition? Think of a battle, right? War. Like सोचो कि इंडिया चाइना का वार हो रहा है on the battlefront. कौन जीतेगा? Obviously India जीतेगा, but obviously it depends on किसकी army बड़ी है, right? If weapons are same, then obviously it is going to depend on whose army is bigger. So if Chinese army is bigger, probably we have to concede the defeat, or if Indian army is bigger, definitely we are going to win. तो यहाँ पे भी न्यूरोमस्कुलर जंक्शन में भी सब कुछ वैसा ही हो रहा है. There's a competition to bind to these receptors by acetylcholine and these antibodies. Antibodies भी इसी को bind करना चाहते हैं, acetylcholine भी इसी को bind करना चाहते हैं. Who will win? Whoever has higher quantity or magnitude. If antibodies ज़्यादा हैं तो वो bind करेंगे, then acetylcholine cannot bind. We will not be able to contract the muscles. अगर acetylcholine ज़्यादा है, then acetylcholine will bind, antibodies may not be able to bind, and we will be able to contract the muscles. Now, one standard thing that we studied when we were discussing about the weakness in the earlier neurology sessions, we learned that there is diurnal variation in patients with neuromuscular junction disorders. And the root physiology is this. Okay, now think of it. What did we learn in myasthenia gravis? As you get up in the morning, you feel energetic. You don't have much weakness, but as the day progresses, the muscles start becoming progressively weak, and by evening you're extremely weak. This cycle keeps on repeating every day. Why is that happening? Because when we go to sleep, during night, we have synthesized plenty of these acetylcholine containing vesicles. Because during night we are not contracting our muscles, we are not moving, right? We are resting. So we have produced a lot of acetylcholine containing vesicles. जब दिन शुरू होता है, when we have to start our day, our nerve terminal will have lot of acetylcholine containing vesicles. So when an electrical impulse comes, we will be able to release larger quantity of acetylcholine. And ये जो large quantity of acetylcholine हम सुबह release कर रहे हैं, that will be able to win in the battle against antibodies. But as the day goes on progressing, हर बार एक एक स्टिमुलस आता जाएगा, तो वी कीप ऑन स्पेंडिंग acetylcholine. तो acetylcholine की क्वांटिटी घटती जा रही है नर्व टर्मिनल में. जैसे ही घटते जा रहा है, हर स्टिमुलस में हम थोड़ा कम acetylcholine रिलीज करते जा रहे हैं. तो जब दिन शुरू हुआ, acetylcholine was more in comparison to antibodies. तो जीता कौन? acetylcholine. So muscle contracted, no weakness. But as day progresses, we started releasing less and less acetylcholine. Antibodies वैसे ही हैं, less and less. एक टाइम आएगा जब acetylcholine antibodies से कम हो जाएगा. At that point of time, antibodies will occupy all your acetylcholine receptors. And now जीत किसकी हो गई? Antibodies की. Will you be able to effectively contract the muscles? No. This is how morning you start a day better. As the day progresses, acetylcholine goes on depleting, antibodies start winning the battles, and by evening, antibodies have taken over the battle. That's how evening will be more weaker. Okay. Now you told me about the Lambert-Eaton myasthenic syndrome. Yeah, वहाँ पे exactly opposite. What happens in Lambert-Eaton myasthenic syndrome? Morning, you're terribly weak. Evening, you're fully energetic. अब वहाँ पे उल्टा क्यों हो रहा है? Because there, so please remember, anti-acetylcholine receptor antibodies are seen in myasthenia gravis, and in case of Lambert-Eaton, we have got anti-voltage gated calcium channel antibodies, जो इस चैनल को टारगेट करने वाले हैं. That is what we see in patients with Lambert-Eaton myasthenic syndrome. वहाँ पे भी it's a competitive inhibition. Means what happens? Antibodies are competing to bind to the voltage gated calcium channels, but किसके खिलाफ compete कर रहे हैं? In myasthenia gravis, the competition was very clear. Acetylcholine and antibodies दोनों acetylcholine receptor के लिए compete कर रहे हैं. In voltage gated calcium channels, antibodies and the voltage of the membrane are competing. So basically what happens, whenever voltage of the membrane increases beyond a threshold, the gates will open. But when the gates are closed, voltage is low, the gates are closed, antibodies occupy all these receptors and make them closed. So for me to get rid of these antibodies, I have to raise the voltage significantly so that we can kick out the antibodies which are bound to the voltage gated calcium channels. अब ये मैं कैसे कर सकता हूँ? When I keep repetitively sending the signals to the voltage gated calcium channels, threshold मतलब membrane का voltage बढ़ता जाएगा, antibodies dissociate होते जाएंगे. So ideally what happens? When we sleep, we are not sending any signal to the neuromuscular junction for a voluntary contraction. So voltage कम है, antibodies will supersaturate all these receptors. So when I get up in the morning and I want to move the muscle, all my voltage gated calcium channels are super saturated with the antibodies. नहीं कर पाऊंगा, I will feel weak. But I keep trying and I keep sending the electrical signals. So जैसे जैसे electrical signals आते जाएंगे, the antibodies start dissociating from the receptors. So time बढ़ते बढ़ते antibodies will go on decreasing at the receptor site, and some point antibodies are significantly reduced and I will start contracting the muscles normally. So that is why in patients with Lambert-Eaton myasthenic syndrome, morning you feel terribly weak, but the more you start using the muscles, the strength goes on increasing. By evening you find. So the rule is very clear. In myasthenia gravis, the more you use the muscle, more weak it becomes because acetylcholine खत्म होते जाता है. In Lambert-Eaton myasthenic syndrome, the more you use the muscle, more stronger it becomes, less weaker it becomes. Clear? Okay, so this is the basic pathophysiology. Okay. So now let us get to the clinical features of myasthenia gravis. Okay. So when we talk about clinical features of any neurological disorder, first thing is we should talk about weakness and the examination findings. One of the common questions that is routinely asked is what is the most common or the earliest symptom, most common or earliest finding in a patient with myasthenia gravis. वो generalized myasthenia gravis हो या सिर्फ eye affected ocular हो. What is the so Tapa, what happens in Lambert-Eaton myasthenic syndrome is the antibodies are targeting voltage gated calcium channels. They are effective in binding to these voltage gated calcium channels. अगर जो membrane है nerve terminal का उसका voltage कम है तो वो आके bind करते हैं, लेकिन अगर membrane की voltage बढ़ता जाएगा तो वो dissociate होने लगते हैं. सो रात भर जब हम मसल्स को मूव नहीं कर रहे हैं तो कोई वोल्टेज या सिग्नल नहीं पहुंच रहा है, तो मेम्ब्रेन का वोल्टेज लो रहेगा तो एंटीबॉडीज आके सब चिपक जाते हैं वोल्टेज गेटेड कैल्शियम चैनल्स तक. तो जब मैं सुबह उठ जाता हूँ तो मेरे वोल्टेज गेटेड कैल्शियम चैनल्स भरे पड़े हैं एंटीबॉडीज से. तो ऑब्वियसली जो इलेक्ट्रिकल सिग्नल्स मैं भेजूंगा इनिशियली इट विल नॉट बी एबल टू क्रिएट अ कॉन्ट्रैक्शन, तो मुझे बहुत वीक फील होगा. लेकिन जब बार बार मैं इलेक्ट्रिकल सिग्नल्स भेजता रहूंगा टू ट्राई टू कॉन्ट्रैक्ट द मसल्स, ट्राई टू यूज द मसल्स, तो वो वोल्टेज हर बार थोड़ा बहुत एंटीबॉडीज को चैनल से हटाने लगेगा. तो दिन बढ़ते बढ़ते एंटीबॉडी लोड ऑन द रिसेप्टर्स घटता जाएगा, मेरा स्ट्रेंथ बढ़ता जाएगा. दैट्स व्हाई एज द डे प्रोग्रेसेस स्ट्रेंथ इंक्रीजेस इन लैम्बर्ट-ईटन माइस्थेनिक सिंड्रोम. राइट, सो द अर्लीस्ट फाइंडिंग और द मोस्ट कॉमन फाइंडिंग इज टोसिस. ओके, टोसिस ही क्यों मोस्ट कॉमन फाइंडिंग है? आई जस्ट मेड अ स्टेटमेंट. In myasthenia gravis, the more you use the muscle, the more weaker it becomes, right? And what happens in like what is the most commonly used muscle in the body? What is the most commonly used muscle in the body? See, right now I'm teaching you, I'm moving my hands, okay, but otherwise if I'm doing other activities I may not be moving my hands. Okay, right now my legs are not moving at all, but eyes, levator palpebrae superioris is constantly blinking, right? Because it is constantly blinking, more and more acetylcholine is being used up. तो acetylcholine किसका सबसे पहले घट जाएगा? levator palpebrae superioris का. So जो बैटल चल रहा है एंटीबॉडीज एंड acetylcholine का टू बाइंड टू द रिसेप्टर्स, उसमें कौन सा मसल पहले हार जाएगा? इट इज levator palpebrae superioris, and that is why ptosis is the earliest symptom. Okay, so in fact you can understand the symptoms by mainly looking at the sequence of involvement of muscles. The earliest muscle to be involved is levator palpebrae superioris, that leads to development of ptosis. After that, the next muscle that gets affected is the extraocular muscles, the muscles of eye movement. Why are they getting affected? Because they are the second most commonly used muscles. Now, when you're listening to my lecture, your eyeballs are moving through the screen and sometimes at me. We are moving our eyeballs constantly. Scene के हिसाब से आंखें घूमते रहते हैं. So these muscles are constantly working. So they become weak. This will result in what we call as ophthalmoplegia, and in terms of symptoms, very often patients will develop diplopia. So that is why most of the patients with myasthenia gravis present with ptosis and diplopia. After that, the proximal group of muscles get affected. Why? Because we use them routinely, right? As soon as you get up in the morning, you want to brush, wash your face, so you're using your proximal group of muscles, right? You're using the proximal group of muscles, biceps to wash your face, the shoulder muscles to brush, shoulder muscles to comb. चलने फिरने लगेंगे तो you're using your hip muscles, thigh muscles, so they become weak. उनका acetylcholine बहुत जल्दी खत्म हो जाता है. So we get this classical proximal weakness that we have already discussed. Okay. After that, the facial muscles get affected. Why facial muscles get affected? Because even face, depending on the situation, right, we have expressions on the face. So expressions कहाँ से आ रहे हैं? By contraction of the facial muscles. So obviously we can't be very mute. Surrounding happy है तो happiness shows on the face, surrounding is sad so it shows up on the face. So we will develop involvement of facial muscles. It will lead to drooping of face, and apart from that, a patient with myasthenia gravis, when facial muscles are involved, if you ask them to give a smile, it gives rise to a very characteristic facial appearance. Can anybody name what is it called? Nilanjana, absolutely right. It is called as snarling face. Okay, can anybody tell me what is snarling? It leads to snarling face. What is snarling? It is a way of defense by dogs. So if you have a pet dog at home, you probably understand. When a stranger comes to the home, right, first thing it does is bark. It tells कि हाँ नजदीक मत हो, जहाँ पे हो वहीं पे रहो, और नजदीक आने की कोशिश करोगे तो मैं आपको हार्म कर सकता हूँ. I can harm you. First barks. Okay, but if you step in further, then it starts producing what is called as growling, right? It stops barking and then starts making a throaty noise called as growling. Grrr, that is growling. If you step little more closer, like you come in its close territory, now it is almost ready to attack, and at this point of time it is also a bit scary. This stops growling and just starts showing its teeth. That expression is what we call as snarling. That is like a last bit warning from the dog. इससे भी और आगे आ जाओगे तो फिर काट देगा. Okay, so these patients of myasthenia gravis, because they have drooping of face, when you ask them to give a smile, see, normally when you ask someone to give a smile, you get a very bright electric smile and the angles of the lip goes wide like this, bright smile. But these patients, because there is drooping of face, they will not be able to lift the angles of the mouth. Thought about lips get lifted and they start looking like their face starts looking like the snarling face of the dog. When you see this picture, probably you can understand. This is what is called as snarling, dog trying to show its teeth. Okay, so this is actually a patient with myasthenia gravis, where you can clearly see this patient has drooping of face and she has been asked to give a smile. So when she was asked to give a smile, she is not able to give a bright electric smile. Only lips are lifted slightly, showing her teeth, kind of resembling the snarling of the dog, and that's why we call this as snarling face. Snarling face. Okay, now I show you one more image here. This image is also trying to give the snarling expression, but I can tell from the image that he is not a patient of myasthenia gravis. Can you tell me what makes me say so that he is not a patient of myasthenia gravis? On what basis I say that he is an actor, not myasthenia gravis, and this is myasthenia gravis? Just look at the eyes. Yes. So this guy does not have the ptosis. Here you can see some degree of ptosis. So this is a true case of myasthenia gravis, and this is someone who is acting like snarl. Clear? Okay. Now after this, there will be involvement of the neck extensors. So after that, they might have difficulty to extend the neck and they may have dropping of the neck. This is a sequence of involvement of muscles. And generally when neck extensors get affected, by that stage, most of the patients will also have involvement of respiratory muscles. So they can develop respiratory paralysis and it can become one of the reasons for death. Now we have fairly understood what clinical features to expect in a patient with myasthenia gravis. Majority of them present with ptosis, diplopia, maybe proximal group of muscle weakness, difficulty to lift object, difficulty to comb, difficulty to brush, difficulty to climb, difficulty to get up from sitting position, along with that facial drooping and snarling face. When I get such a patient, particularly a young female, first thing that should come to my mind is this is a case of myasthenia gravis. That too when history is very clear that morning सब ठीक है, शाम को ये सब आ जाता है. I know this is mostly a case of myasthenia gravis. Now, how do I take it to the diagnosis from here? Obviously, I will start examination, and on examination, I may be able to see the ptosis and ophthalmoplegia, and I may be able to see the snarling face. So Tapa, absolutely right. Snarling face, and I may be also able to prove that patient has got proximal muscle weakness by checking the strength of the muscles. Okay. Now, whenever we have a patient with muscle weakness, we do examine them for tone, deep tendon reflexes, and the plantar response. Now, you should tell me what will happen to tone, what will happen to deep tendon reflex, and plantar response. I've already told you, typically tone gets increased, deep tendon reflexes get exaggerated, and plantar becomes extensor, or what we call as Babinski, when there is a damage to upper motor neuron, means brain to subcortex to brainstem to spinal cord. When lower motor neuron, that is anterior horn cell to the neuromuscular junction, if there is a damage, we get decrease in tone, deep tendon reflexes, and plantar response will be flexor, right? What happens in myasthenia gravis? Myasthenia gravis does not belong to upper motor neuron or a lower motor neuron because it is the disease of neuromuscular junction. Neuromuscular junction is a junction between a nerve and muscle. This is not a motor neuron, right? So what will happen to tone? The tone will be normal, deep tendon reflex will be normal, and the plantar will also be normal, which is a flexor response, right? Everything will be normal. So what we found, the typical examination findings that we just discussed, but the tone, deep tendon reflex, plantars will not show any abnormality. Okay. So once we have done that, we have to investigate to take it to the diagnosis. Now, most of the questions asked in the recent 2 years exams are about investigations. Okay, so first investigation is what is the screening test of choice. Second MCQ they will ask you is what is the most sensitive test. They will ask you what is the most specific test. And then they will also ask you what are the other tests that are available. Okay, so Nilanjan, absolutely right. The screening test, ideally a screening test is the one which should be very convenient, safe, and highly sensitive, right? Highly sensitive. A confirmatory test is one which is supposed to be highly specific. Okay, but screening test should be absolutely very safe. We can't take a risky investigation as a screening test, right? So we generally perform a test called as ice pack test for diagnosis or the screening of myasthenia gravis. So what we do in ice pack test, we take an ice pack and ask the patient to hold it against the eye which is having ptosis. So if the patient holds it on the eye which is having ptosis, we will hold it for a few minutes and we will remove and examine what happened to ptosis, whether ptosis persists or improves. Now you should tell me what happens to ptosis. So Tapa, good. What happens to ptosis if it is a case of myasthenia gravis? In the ice pack test, what happens to ptosis if it is a case of myasthenia gravis? So when we apply ice pack, right, what is happening to the blinking? Blinking is almost stopped, right? We are utilizing acetylcholine when we are blinking. So we are losing acetylcholine, and that's why muscle is becoming more and more and more weak. The more we use the muscle in myasthenia gravis, the more weak it becomes. But when we apply an ice pack, we have rested the levator palpebrae superioris. So now during this rest period, we will be able to synthesize some acetylcholine. So जब हम remove करेंगे, so we would have increased the acetylcholine in the neuromuscular junction of levator palpebrae superioris. And relatively against antibodies, we may be able to win the battle with the acetylcholine. So the ptosis will disappear. So when you see this image, you can understand. You can notice significant ptosis on this eye of the patient. He is holding the ice pack, and then ptosis disappears. So if ptosis improves on ice pack test, it indicates that you have got myasthenia gravis. It's a very convenient, simple screening test, not routinely practiced by many clinicians because all are busy, nobody has time, and everyone just prescribes the blood tests or other investigations. But this is something that you should try if you're suspecting a patient having myasthenia gravis. You will be able to get a good result. Okay. So what happens? It is positive, means doses improves. Okay. Most sensitive test, Nilanjana, right? The most sensitive test is called as single fiber electromyography. Single fiber electromyography. Now, what is it? So, this is a test where you repetitively stimulate a muscle fiber. Now, whether muscle is contracting well or not, how will I assess? By calculating its action potential, right? We will call it as muscle action potential. Now, if I repetitively stimulate a single muscle fiber and see what happens to its action potential. If it is a case of myasthenia gravis, what should I get? The action potential should go on increasing or should go on decreasing after I repetitively stimulate a single muscle fiber. Remember, I have already made a statement. In myasthenia gravis, the more I use the muscle, the more weaker it becomes. In Lambert-Eaton, the more I use the muscle, more stronger it becomes. So in myasthenia gravis, if I repetitively stimulate a muscle by giving electrical impulses, I'm using the muscle more and more. So what should happen to the force of contraction? Should go on decreasing because acetylcholine is all getting used up, right? The force of contraction will go on decreasing. So muscle action potential will go on decreasing. So this is what, yes, in myasthenia gravis, it need not always be perfectly symmetrical. Asymmetrical ptosis or asymmetrical presentation is known to occur. So because of that, at the time of presentation, patient may have ptosis only in one eye also. Okay. So you will get the response where decrease in action potential happens. So we call it as decremental response. Decremental response. This was a question that was asked in the recently concluded FMG. Like, how do you differentiate based on the SAPMG or the repetitive nerve stimulation test between myasthenia gravis, botulism, and the Lambert-Eaton myasthenic syndrome? So in Lambert-Eaton and botulism, you get incremental response. In myasthenia gravis, the strength goes on decreasing. So we get decremental response. Okay, clear? Now they will also ask you what is the most specific test. The most specific test is finding the antibody against acetylcholine receptor. So anti-acetylcholine receptor antibody is the most specific test. Okay. What other tests we can do? One of the other tests, which is actually the most commonly performed test these days, that is repetitive nerve stimulation test. So what is this? How is it different from single fiber electromyography? Not much different. Main difference is that in single fiber electromyography, you have to isolate a single muscle fiber and stimulate it repetitively. But it is a very cumbersome process. Instead, in repetitive nerve stimulation, just hold a nerve which is supposed to supply a particular muscle. Like for example, if I have to do this test for biceps, then I should know the surface anatomy of the musculocutaneous nerve, pick up a point where I can be able to stimulate the musculocutaneous nerve. So repetitively, I will stimulate the musculocutaneous nerve. The electrical impulse will travel to the neuromuscular junction between biceps and the musculocutaneous nerve, right? And thus, if I more and more stimulate, what will happen to the biceps contraction? Goes on decreasing. So the muscle action potential that we are measuring here is not from single fiber, but the whole muscle. So we call it as compound muscle action potential. So in repetitive nerve stimulation test, we stimulate the nerve at a frequency 2 to 5 hertz. Okay, and then we will measure the compound muscle action potential. We will measure the compound muscle action potential. On repetitive stimulation, if it increases, right, increases by more than or equal to 10%, or if it decreases by more than 10%, more than or equal to 10%. So if it is increasing, we will call it as incremental response. If it is decreasing, we will call it as decremental response. So where we get incremental response? I just told you, right? When we were talking about single fiber electromyography, incremental response. So if you get an incremental response on SFEMG or the repetitive nerve stimulation test, think of Lambert-Eaton myasthenic syndrome and botulism. These are the two conditions where it goes on increasing. The more I stimulate the muscle, more stronger it's going to become. But in patients with myasthenia gravis, we get what is called as decremental response. Decremental response. So if you get decremental response, it should suggest myasthenia gravis. Clear? Okay. Now what other tests we can do? We can also do a test called as tensilon test or edrophonium test. Nowadays it is not very commonly performed. Tensilon test or edrophonium test. So what is this edrophonium? Chemically, what is it? Nilanjan, absolutely right. What is this tensilon test or edrophonium test? What is the edrophonium chemically? So edrophonium or tensilon are chemically basically acetylcholine esterase inhibitors, right? So what do? They block the acetylcholine esterase. So if I block the acetylcholine esterase, what will happen to the amount of acetylcholine in the synaptic cleft? Normally, once acetylcholine released, goes and binds to the receptor. After that, it gets converted to choline by this acetylcholine esterase enzyme. But if I block the enzyme, the acetylcholine will start increasing. So basically, यहाँ पे क्या चल रहा है? एक battle, fight चल रहा है between antibodies and acetylcholine. अगर मैं acetylcholine degradation को block करके acetylcholine को increase कर दूंगा, तो battle में कौन जीतेगा? Acetylcholine. Antibodies तो उतने ही रह गए. So if acetylcholine starts winning, what will happen to the ptosis and other symptoms? They will show improvement. So upon administration of edrophonium, if ptosis and other symptoms improve, that proves that you have got a case of myasthenia gravis. If they do not improve, then it is not a case of myasthenia gravis. But why is it not routinely performed these days? Ptosis improves if it is a case of myasthenia gravis. It is compound muscle action potential. मतलब action potential of all the muscle fibers in a given muscle. That's why it's called as compound muscle action potential. If I take it from only one fiber, I will call it as action potential of that fiber. Okay. So why is it not commonly performed? Because when I give an acetylcholine esterase inhibitor, I will increase the acetylcholine in the body, not only in the neuromuscular junction of skeletal muscles where we have the nicotinic receptors, but also in other locations where we have the muscarinic receptors. They get hyperstimulated. So because of that, you can get a condition very similar to cholinergic crisis. The patient will start salivating, lacrimating, urinating, defecating. So we call it as all LEMS symptoms. They can appear. So it is quite cumbersome, right? Like patient is suspect of having myasthenia gravis. आपने एक injection दे दिया, फिर patient starts leaking fluids from all his orifices. Doesn't look good or not very comfortable for the patient. So we have kind of given up on it. And nowadays, most commonly performed investigation is the repetitive nerve stimulation test, because this test not only establishes the diagnosis myasthenia gravis, अगर if it is botulism or the Lambert-Eaton, वो भी हम इसी टेस्ट से क्लियर करा सकते हैं, right? That is why right now it is the most commonly performed test. Along with that, acetylcholine receptor antibody हमेशा check करते हैं. We check that because the management is kind of dependent on antibody positive है या negative है. I'll tell you about that in a bit. Okay. So I hope we have a fair idea about the diagnosis. Screening test ice pack करेंगे. Sensitive कौन सा है? Single fiber electromyography. Sensitive है लेकिन वो routinely क्यों perform नहीं करते हैं? Because it's a very cumbersome test to isolate one muscle fiber and keep repetitively stimulating it. Alternatively हम क्या करते हैं? Mostly we go ahead with the repetitive nerve stimulation test. So instead of stimulating one fiber, we will stimulate the whole muscle and see what happens to the action potential. घटता जाता है decremental response, then we have myasthenia gravis. उसके बाद में we definitely do the antibody, because antibody will decide how we manage the case. Okay. Now coming to the management. How do you manage a case of chronic stable myasthenia gravis? Okay. So now, if I have to make this patient's life better, how can I manage it? See, I'll tell you. This is a battle that is going on between antibodies and the acetylcholine. तो अगर मुझे पेशेंट के सिम्टम्स इंप्रूव करना है तो acetylcholine को बढ़ाना होगा, एंटीबॉडीज को घटाना होगा. That is how we win the battle, right? So first tell me, how can I increase the acetylcholine? I can increase the acetylcholine by giving acetylcholine esterase inhibitors, right? So if I inhibit the acetylcholine esterase, then I will have more and more acetylcholine in the nerve terminal. So एक तरीका है acetylcholine को increase करने का. But how can I reduce the antibodies? How can I reduce the antibodies? Nilanjana, absolutely right. So for increasing the acetylcholine, we preferably use the pyridostigmine because of its long-acting stable form. So and can be administered orally. So we use pyridostigmine. We have more potent but short-acting forms which are not routinely used in a patient with myasthenia gravis. We would use pyridostigmine. Okay, that is the drug of choice. Okay. Now coming to how I can reduce the antibodies. So tell me, who is producing the antibodies? Botulism is a disorder where you are being troubled by a toxin called as botulinum toxin. Botulinum toxin produced by a bacteria. Nilanjana, good. Plasmapheresis applies to critical conditions or crisis situations. जो chronic stable myasthenia gravis patient है, उसका problem क्या है? Morning I wake up, I'm fine. As the day progresses, I develop ptosis, diplopia, शाम तक extremely weak, chair से उठ भी नहीं पाता हूँ. That this is the story, not an emergency. So here I don't need to absolutely bring down the antibodies quickly. धीरे धीरे से मैं कर सकता हूँ. So how can I do that? Which cell produces the antibodies? Plasma cells or B lymphocytes? Not T. Plasma cells or B lymphocytes. इनके एक्टिविटी को मैं कैसे कम कर सकता हूँ? One mechanism is to give steroids. Right? Steroids. Now, when I give steroids, obviously they do bring in a set of side effects, right? What side effects to expect if you give steroids to someone? So to increase acetylcholine, what should I give? I should give acetylcholine esterase inhibitor, right? That will be what I will be giving. And here the drug of choice is pyridostigmine. It's a stable, relatively long-acting oral form. Okay. And to decrease antibody load, what can I do to decrease the antibody load? Steroids. But steroids, as I told you, have side effects. What all side effects we can expect? Starting from head to toe, corticosteroids can cause alopecia. Corticosteroids can cause acne. Corticosteroids can cause oral candidiasis or oral thrush, right? Repetitive throat infections. Corticosteroids can cause redistribution of body fat, so you can develop buffalo hump, abdominal obesity, right? What you see in Cushing syndrome, pink purplish stripe. You can develop osteoporosis. To the GIT, it can cause ulcers, right? When you think of peptic ulcers, you think of NSAIDs and steroids and H. pylori. That's it, right? And then to the hip joints, it can cause avascular necrosis. So long list of. But I want to give steroids, but if I continue for long or give higher doses, I have side effects. So how can I reduce the activity of plasma cells or B lymphocytes with minimal dose of steroids? By giving other drugs which can suppress the activity of B lymphocytes or the plasma cells. What we call them as, we will simply call them as immunosuppressants. So generally what we do is, we give corticosteroids in low doses, right? We give low dose corticosteroid and we can achieve a good suppression of B lymphocyte activity and plasma cell activity by giving immunosuppressants, right? So we can give drugs like azathioprine, immunosuppressants like azathioprine or mycophenolate mofetil or tacrolimus. These are all immunosuppressants. They can be added. Most commonly, we use azathioprine along with low dose corticosteroids. So corticosteroids and azathioprine की वजह से plasma cell B lymphocyte activity will decrease. So with that, antibodies will start decreasing. With pyridostigmine, acetylcholine will increase. So now in the battle, acetylcholine is consistently winning and patient will have a symptom-free day. Okay. But sometimes patients might present late or they may not be consistent with the drugs. And because of that, see, as I told you, whenever there is involvement of neck flexors, I told you invariably there will be involvement of respiratory muscles. And if there is involvement of respiratory muscles, they can develop respiratory paralysis. So sometimes patients can present with impaired respiration. That is life-threatening. Such situation is what we call as myasthenic crisis. We call it as myasthenic crisis. So another thing that they will ask you is, how do you manage a patient with myasthenic crisis? So first, let me define what is myasthenic crisis. Myasthenic crisis refers to severe myasthenia gravis leading to respiratory paralysis. And whenever we have respiratory paralysis in such patients, we might have to put them on ventilator, right? Respiratory paralysis mandating ventilatory support. Mandating ventilatory support. Okay. Now in this case, how should I manage? See, again, यहाँ पे क्या हो रहा है? एक acetylcholine and antibodies का battle है. यहाँ पे antibodies are way more. Too less acetylcholine, तो तगड़ा battle है, and antibodies are grossly winning. Now, if I have to win this battle, what should I do? How do I manage? Yes, first point is absolutely true. As soon as you recognize that patient is in myasthenic crisis, means he's having respiratory paralysis, ABG showing rise in PCO2, decrease in PO2, you have to put them on mechanical ventilator, because till he gains the muscle strength, he's not going to breathe properly and he will die by the time you complete the treatment. So you have to put them on mechanical ventilator. But you have to also quickly gain the muscle strength so that we can get him off ventilator. जितने दिन ज़्यादा रखोगे वेंटिलेटर पे उतना ही कॉम्प्लिकेशंस लाइक वेंटिलेटर एसोसिएटेड निमोनिया, वेंटिलेटर डिपेंडेंस, वो सब बढ़ता जाएगा. सो आई हैव टू bring him back from the ventilator as soon as possible. How can I bring him back? By increasing the muscle strength. How can I increase? By quickly reducing the antibodies. यहाँ पे quickly increasing the acetylcholine may not work magic, because if you have to quickly increase the acetylcholine, you have to give short acting acetylcholine esterase inhibitors. आप बार बार नियोस्टिग्मिन फाइसोस्टिग्मिन देते रहो जाओगे, but antibodies are not going to come down. मुझे यहाँ पे antibodies को quickly decrease करना है. How can we do that? Right, absolutely right. So to reduce the antibodies quickly, if I give steroids, it's not going to work, because if I give steroids today, जो plasma cells and B lymphocytes हैं, वो आज काम करना कम करेंगे. But whatever antibodies they've already produced, they are going to be in circulation. They are not going to come down. They will finish their half-life and then they will get disintegrated. तब तक तो वो block करते रहेंगे neuromuscular junction को. So those circulating antibodies को मुझे कम करना है. So how can I do that? Either I have to remove the antibodies from the blood through a method called as plasmapheresis, or I have to give IV immunoglobulins which have the capability to neutralize these circulating antibodies. So we can use either plasma exchange, which is conventionally we can also call it as plasmapheresis, plex or plasmapheresis, or we can use IV immunoglobulins, IVIG. How do they work? By reducing सर्कुलेटिंग एंटीबॉडीज. तो जैसे ही सर्कुलेटिंग एंटीबॉडीज कम होते जाएंगे, at some point of time acetylcholine के बैटल में they will become much lesser in strength and acetylcholine will have a higher strength and muscle function will be recovered, and then we can take the patient off ventilator. Clear? Now one more question that routinely asked is, if I have given this plasmapheresis treatment or plex, basically plex में क्या होता है, patients blood is removed from the body, made to run through a plasmapheresis machine, right? And then we try to extract the antibodies, or we can do exchange transfusion. Patient का 300 ml 400 ml plasma निकाल देंगे and किसी और healthy donor का plasma patient को चढ़ा देंगे. So whenever 300-400 ml of plasma come out, whatever antibodies that were there in that is removed from the body. So when we do these multiple cycles over 4 to 5 days, we would have significantly reduced the antibodies. Okay. So let me say that I have tried this plasma exchange for a patient. He's not showing improvement. Now should I try the IVIG? Niranjana, absolutely right. Yeah. So if I have tried plasmapheresis or plex and it did not work, should I try IVIG? Or vice versa? I've given IV immunoglobulins, did not show much improvement. Should I give plasmapheresis or plasma exchange treatment? The answer is no, because दोनों का वर्किंग प्रिंसिपल सेम है, राइट? बोथ ऑफ देम हैव सिमिलर वर्किंग प्रिंसिपल. दे रिड्यूस द सर्कुलेटिंग एंटीबॉडीज. तो अगर आपने प्लाज्मा एक्सचेंज किया तो एंटीबॉडीज वुड हैव कम डाउन. इफ स्टिल पेशेंट इज नॉट शोइंग इंप्रूवमेंट, देन देयर मे बी अदर फैक्टर्स लाइक न्यूट्रिशन एंड अदर थिंग्स दैट नीड्स अटेंशन, नॉट गोइंग विद IVIG or the vice versa. Now studies have shown that IVIG is slightly superior to plasmapheresis or plasma exchange. बट रिकमेंडेशन इज नॉट कि हाँ सारे पेशेंट को IVIG ही देना चाहिए. इट इज अ मैटर ऑफ कन्वीनियंस. Because superiority is only slightly. I don't say that IVIG is greatly superior to plasmapheresis. So that is why जिस सेटिंग में आप प्रैक्टिस कर रहे हो वहां पे जो भी प्रैक्टिकली पॉसिबल है और पेशेंट के रिसोर्सेज में कन्वीनियंट है, पेशेंट के बजट में आता है, वो ऑफर कर दो. IVIG is generally more costlier than the plasmapheresis. Whichever is available, we can. Yeah, if it is a chronic stable, see here what we discussed was for a patient with chronic stable myasthenia gravis, not going through respiratory paralysis, such patients, we can treat them on outpatient basis. In fact, there is a famous celebrity who is said to be a patient of myasthenia gravis. Matlab in India, myasthenia gravis ka discussion without taking the name of the celebrity isn't complete. And obviously, he is not taking a treatment in hospital. He was treated outpatient. Yeah, plasmapheresis, antibody extraction, and in plasma exchange, we are literally exchanging the patient plasma with the donor's plasma. So plasmapheresis is finally done on a machine which is also used for extraction of platelets and other blood cell components. So I don't know very surely that it is true or false, but there is a general dictum or general saying among medical community that a film star who also ran KBC was suffering from myasthenia gravis. And you go to any medical college and whoever teacher comes to talk about myasthenia gravis opens by talking a little bit about him. And Niranjan, yeah, completely we cannot remove, right? Like if you have to remove antibodies, then you have to remove all the globulins from the body. Not possible, but by reducing the load, ultimately it's a battle. हमको एंटीबॉडीज को इतना नीचे लेके जाना है ताकि एसिटाइलकोलिन उसके कंपैरिजन में क्वांटिटी में ज्यादा हो एंड वी विल बी विनिंग द बैटल. ओके, so this is the treatment for KK, right? True. So this is the treatment for myasthenic crisis. Okay, now I'll ask you a question. That is the last point for us to learn today. How many of you have seen a patient with OP poisoning in your hospitals? Organophosphate compounds. हाँ, तब समझता जो myasthenia gravis का कॉमन सिम्टम क्या है? टोसिस, डिप्लोपिया, प्रॉक्सिमल मसल वीकनेस. अगर एक पेशेंट में सिर्फ इतना ही सिम्टम्स है तो वी विल कॉल इट एज chronic stable myasthenia gravis. But if it is severe, affecting the respiratory muscles, causing respiratory paralysis, जिसको हमको वेंटिलेटर पे डालना पड़ रहा है, तो we call it as myasthenic crisis. Okay. So जो बाकी सब पेशेंट्स हैं जहाँ पे रेस्पिरेटरी मसल्स इन्वॉल्व नहीं है, ज़्यादा कुछ करने की जरूरत नहीं है. गिव देम pyridoxine, give them steroids and azathioprine. Okay, but those who are in a crisis situation, that is respiratory paralysis, उनमें वो ट्रीटमेंट काफ़ी नहीं है because it takes sweet time to start working. हमको क्विकली एंटीबॉडीज क्लियर करना है. फॉर दैट वी फॉलो प्लाज्माफेरेसिस और IVIG. Okay. Now, how many of you seen a patient with organophosphate compound poisoning? Okay, forget about seeing the patient. What is the antidote for organophosphate compound poisoning? Antidote for OP poisoning, common basic thing ना, इंडिया में आपको पता होना चाहिए. What is the antidote? So all your organophosphate compound poisons are basically acetylcholine esterase inhibitors. Atropine, absolutely right. Okay, why are we giving atropine? Because in OP compounds, they are organophosphate compounds and organochloride compounds are inhibitors of acetylcholine esterase. So when they inhibit acetylcholine esterase, what will happen to the acetylcholine? Acetylcholine increases. This increased acetylcholine is the problem in a patient with organophosphate compound poisoning. And why are we giving atropine? Because atropine is an anticholinergic, right? यहाँ पे choline ज़्यादा है, they are giving an anticholinergic. Simple. Can a OP poisoning patient die? Yes, they very commonly die. What is the reason for death? Why a OP poisoning patient dies? OP poisoning patient dies because of respiratory failure or respiratory paralysis. See, in myasthenia gravis, what happened? There was relatively less amount of acetylcholine in the neuromuscular junction, so respiratory muscles were not stimulated, they were not able to contract, and we developed respiratory paralysis. Now, in organophosphate compound poisoning, there is too much of acetylcholine. Then why am I still getting respiratory paralysis? Yes, KK, absolutely right. But why am I getting respiratory depression when there is too much of acetylcholine? So when you become intern and see your first case of organophosphate poisoning, right? Open his chest shirt and see the chest. You will notice that all muscles are having fasciculation. They are contracting little. Why are they contracting? Because this excess acetylcholine in synaptic terminal means what? More binding of the acetylcholine receptors, more stimulation of the muscle, and muscle is going to contract more. लेकिन मसल कितना कॉन्ट्रैक्ट कर सकता है? ज्यादा कॉन्ट्रैक्ट करते करते ऑल द एटीपीज एंड मेटाबोलाइट रिजर्व दैट मसल हैज विल ऑल बी यूज्ड अप. मतलब सेम थिंग हैपेंस इन द जिम, राइट? जब आप डंबल उठाने लगोगे तो 10 बार, 15 बार, 20 बार, उसके बाद यू कैन नॉट कंटिन्यू बिकॉज मसल्स हैव लॉस्ट ऑल द ग्लाइकोजन स्टोर, ऑल द ग्लूकोज एंड एटीपीज. सो अब कॉन्ट्रैक्ट करने के लिए एटीपीज जरूरी है, नहीं है, दे आर नॉट एबल टू कॉन्ट्रैक्ट. Same thing happens to these muscles in organophosphate poisoning. Because of too much of acetylcholine, there is hyperstimulation of the muscle. तो muscle contract करते रहेंगे कुछ देर तक, lose all their glycogen ATP reserve, and then they will not be able to contract. So that will also lead to respiratory paralysis. Myasthenic crisis can lead to respiratory paralysis, but similarly, if acetylcholine increases, that can also lead to respiratory paralysis. Now, for a myasthenic gravis patient, we are giving pyridostigmine, right? What is it? Pyridostigmine is also an acetylcholine esterase inhibitor, right? It's an acetylcholine esterase inhibitor. So this can also increase acetylcholine. Agar galti se, if I am giving too high dose of pyridostigmine, or a patient is taking too much dose of pyridostigmine kyunki usko lag raha hai ki I'm still tired, can I get into a very similar situation that we see in patient with OP poisoning? Yes. So now if I get a myasthenia gravis patient with difficulty breathing, I have two possibilities. It could be a myasthenic crisis, or it could also be because of overdose of pyridostigmine. In that case, we call it as excess acetylcholine. तो क्या कहेंगे? Cholinergic crisis. तो दोनों possibilities है. तो now question क्या है? How will I differentiate between the cholinergic crisis and myasthenic crisis? How will I differentiate between cholinergic crisis and myasthenic crisis? Because a patient with myasthenia gravis may present with both. So how can we differentiate? दोनों में the main symptom क्या है? To call it as crisis, it is the respiratory failure. Cholinergic crisis में because of excessive acetylcholine, myasthenic crisis में deficiency of acetylcholine. So myasthenia gravis presenting with respiratory failure can either have cholinergic crisis or myasthenic crisis, right? So pathology क्या है? In cholinergic crisis में there is increase in acetylcholine, and in myasthenic crisis there is relative deficiency of acetylcholine. Okay. So clinically हाँ एक एड्रोफोनियम टेस्ट कर सकते हैं, but clinically how can we differentiate? Look at the patient's pupils. Pupils will hold the first clue. Okay. So if you give atropine to somebody's, if you put atropine drops to somebody's eyes, what will happen to the pupils? When you're posted in ophthalmology, right, you dilate the pupils. What do you use? Nilanjana, true. When you put atropine or similar drops to the eyes, what happens to the pupils? They become dilated, right? So that means anticholinergics cause pupil dilation. But if cholinergic excess, what will happen to the pupil? It will get constricted. So when it is constricted, what we call it as meiosis, right? When it is constricted, we call it as meiosis. In myasthenic crisis, we will not see the pupil constricted because यहाँ पे acetylcholine की deficiency है, right? So it will not be constricted. It will be non-constricted. So that is the first clue that can help you to clearly differentiate. Okay. The other thing we can see is what we call as sludge symptoms. Sludge here refers to salivation, lacrimation, urination, gastric symptoms, mainly pain abdomen, and emesis or vomiting. These are classical symptoms of excess acetylcholine. These are called as cholinergic symptoms. Excess acetylcholine. Exactly opposite of this happens when someone takes too much of atropine. Right? Every secretion becomes dried. That is why in anesthesia postings, you might realize that anesthetists often give a drug called as glycopyrrolate, which is also an anticholinergic agent to reduce the secretion. जब anesthesia दे रहे हैं, airway secretions, if it is too much, it will interfere with the ventilation of the patient. So उसको कम करने के लिए they give glycopyrrolate, which is an anticholinergic. Anticholinergics reduce secretions, make you dry, and because they are reducing sweating and all, very often body temperature significantly increases. So when you give atropine, body temperature increases. Opposite of it when acetylcholine increases, right? So you can have salivation, lacrimation, urination, defecation, gastric symptoms, and emesis. So they will be present in a patient with cholinergic crisis. They will be absent in a patient with myasthenic crisis. इसके बाद भी अगर हमको क्लैरिटी नहीं मिल रहा है तो एज अ लास्ट रिजॉर्ट वी कैन गो फॉर द टेंसिलॉन टेस्ट. What do we do in tensilon test? We administer edrophonium or the other acetylcholine esterase inhibitors like neostigmine or physostigmine. Okay. Now, if I administer an acetylcholine esterase inhibitor to a patient with cholinergic crisis, what will happen to the patient's situation? Will it improve or worsen? I'm blocking the acetylcholine esterase more by giving an acetylcholine esterase inhibitor. So what will happen to the acetylcholine? It will further increase. So what will happen to the symptoms? It will lead to worsening of symptoms. On the other hand, if I do that for a patient with myasthenia crisis, it will show improvement in the symptoms. Improvement in symptoms. Yes. So these points will help us to differentiate between cholinergic crisis and myasthenia crisis. Many a times they give you an MCQ where it's like a known case of myasthenia gravis, presented with difficulty breathing, saturation is low, ABG shows increased carbon dioxide, decreased oxygen, patient's breathing is shallow, respiratory rate is low, patient was immediately put on the ventilator, and then they will mention one or two of these findings that we discussed, and they will ask what is the diagnosis. Is it cholinergic crisis or myasthenic crisis? So you should be able to differentiate by looking at this table. Okay. So that concludes our discussion on myasthenia gravis. I have last one thought process, that is sometimes we remove the thymus gland for a patient with myasthenia gravis. Right. Do we do that for all patients? Let us presume that Amitabh Bachchan has myasthenia gravis. True है, false है, पता नहीं, but there is a common saying among the medical fraternity that he is a case of myasthenia gravis. So let us presume. Have you seen him, like in many movies, he has been bare chested and all, right? Have you seen any scar on the chest suggestive of mediastinum being opened and his thymus gland being removed? No. तो इसका मतलब क्या है? थाइमेक्टमी का कुछ रोल शायद होगा, but it is not for all patients. So what examiners will ask you? Where is it indicated? मतलब कौन से myasthenia gravis पेशेंट में thymus gland रिमूव करते हैं? Right. So thymectomy in myasthenia gravis. So thymectomy is indicated for only patients, because what we have understood from the experience and studies is that thymectomy is useful for only those patients who have acetylcholine receptor antibody positive. If you have anti-MuSK or anti-LP4 receptor antibody or any like no antibodies present, such patients do not respond to thymectomy. You don't get any added benefit. So just stick to them giving steroids, immunosuppressants and pyridostigmine. Lekin if you have acetylcholine receptor antibody positive, then removal of the thymus gland will make a lot of improvement. We will be able to manage you subsequently with minimal dose of steroids, minimal dose of immunosuppressants, or sometimes only immunosuppressants and no steroid. That is the benefit of removal of the thymus gland. But कौन से पेशेंट में करते हैं? एंटी एसिटाइलकोलिन रिसेप्टर एंटीबॉडी पॉजिटिव होना चाहिए, एंड एज ऑफ द इंडिविजुअल आइडियली शुड बी लेस देन 55 years. Some books now mention 65 years because surgery is becoming safer. More than 55 years क्यों कंसिडर नहीं कर रहे हैं? Because thymus gland removal is a major surgery, and after 55 years it is not considered very safe. But now some guidelines are pushing it to 65 because surgery is becoming safer and refined, right? So it is indicated for patients with generalized myasthenia gravis, which is seropositive. Seropositive किसको बोलते हैं? Those patients who have anti-acetylcholine receptor antibody positive, anti-ACH receptor antibody positive cases, and the age of the individual is less than 55 years. According to the API textbook of medicine, it is less than 65 years, obviously depending on other patients' parameters. Yeah, post-thymectomy, significant reduction in antibody happens. So a sizable chunk of patients may not require any further steroids or immunosuppressant. A small chunk of patients might require significantly lower doses of immunosuppressant and steroid that we would probably be using much higher before thymectomy. Yeah, a reasonable number of them, we will be able to take them off completely, the immunosuppressants and steroids, and only symptomatic management with pyridostigmine. A reasonable chunk, reduction in the dose. that so that okay, all the side effects of immunosuppression and the steroids are reduced. Okay, so this is about the myasthenia gravis. I will share few MCQs on the Telegram, and hopefully you should be able to solve, and you can also hit the QBank section of the app and solve all the questions on myasthenia gravis. So I will see you in the next class. In the next class we will be talking about I think we have scheduled the GB syndrome, so read a little bit about it and then come, we'll be able to help. Okay, a few points about Lambert-Eaton also. So Lambert-Eaton myasthenic syndrome, as we know, right? It's a not a perfect autoimmune disorder. It is a paraneoplastic syndrome. It's a paraneoplastic syndrome. Now, what do I mean by paraneoplastic syndrome? Can anybody tell me? And it is a presynaptic neuromuscular junction disorder. Myasthenia gravis is a postsynaptic NMJ disorder. It is a presynaptic NMJ disorder. Okay. Now you know medical and paramedical, right? Medical is like you're directly involved in the patient care. Paramedicals are assisting you in patient care, like the pharmacist, staff nurses, physiotherapists. They're all assisting you in patient care. You're directly involved in patient care. Medical, something related to sidewise paramedical, right? You know, sternum, parasternal region. Similarly, neoplasia means cancer, right, or a tumor. Paraneoplastic syndrome means some manifestations which are not directly caused by the tumor, like tumor's physical presence. For example, if I have a tumor in the apex of my lung, what you call as the Pankos tumor, it can compress the superior vena cava, cervical sympathetic ganglion, right? Can cause pupillary abnormalities, neck vein distension, all of that, right? That is a direct manifestation of the tumor, right? Tumor compressing the surrounding structures. Tumor eats a lot of calories, so I lose weight, I become emaciated. Again, a direct manifestation. But sometimes the tumors can produce substances which can get released from the tumor, go elsewhere, and do some damage. So such manifestations which are indirectly caused by the tumor, we call them as paraneoplastic syndromes. So Lambert-Eaton myasthenic syndrome is also one such syndrome. Means here antibodies are not produced by your plasma cells or the B lymphocytes. The voltage gated calcium channel antibodies that are seen in these patients are produced by the tumors, right? So this is a presynaptic neuromuscular junction disorder where there are antibodies against voltage gated calcium channels produced by the cancers. So then one MCQ they will ask you is, what is the most common cancer associated with Lambert-Eaton myasthenic syndrome? So please remember, when you think of paraneoplastic syndromes, there are only two things that should come to your mind. One is lung cancer. The second one is hematological malignancies. So this is the most common cancer associated with the Lambert-Eaton myasthenic syndrome is carcinoma of the lung. Okay, I will leave you with a small homework. So in terms of treatment, even now, the best way to treat Lambert-Eaton myasthenic syndrome is to treat the underlying cause, right? If the cancer is in a treatable stage, you will be able to treat it. If you treat the cancer, the cancer cells are the ones which are producing the antibodies. So if the cancer cells decrease, antibody production decreases, and patient will come out of Lambert-Eaton myasthenic syndrome. But in the very recent times, we have developed some drugs which act through certain electrolyte channels, which can make the patient's symptoms a little better. So I want you to make a list of the recently approved drugs for the Lambert-Eaton myasthenic syndrome. I will discuss about the drugs and the channels in the tomorrow's class. Okay. So next class will be about the GB syndrome. Okay. So the see, basically when B lymphocytes produce antibodies, right? वो खुद ब खुद किसी एंटीजन के खिलाफ एंटीबॉडीज प्रोड्यूस नहीं करते हैं. दे आर नॉट कैपेबल. बेसिकली ये एक सोल्जर के जैसे, बी लिम्फोसाइट्स आर लाइक सोल्जर्स. उनको एक कमांडर चाहिए, वो बोलता है कि हाँ ये जो चाइनीज सामने दिख रहा है वो हमारा एनिमी है, मारो उसको. So then they start producing the antibodies. So who is giving those antigens to the B lymphocytes? What we call as antigen presenting cells, right? Antigen presenting cells are derivatives of T lymphocytes, and all this T lymphocyte maturation and all happens in the thymus gland. So it is like if you have to kill your enemy, instead of only targeting the soldiers, टारगेट देयर कमांडर, मतलब एक टेरर कैंप का जो ट्रेनर है उनको टारगेट कर. दैट्स द प्रिंसिपल, simple principle mechanism behind the thymectomy. And now recent studies have also shown that 20 to 25% of the patients with myasthenia gravis, especially with acetylcholine receptor antibody positive myasthenia gravis, they have thymus gland hyperplasia, very much evident on the thoracic CT scans. So removing the thymus gland reduces the training of the B lymphocytes for production of antibodies, and antibody production will come. Okay. Nilanjana, no, it is not an NMG related carcinoma. Cancer in the lung produces substances which act as antibodies and block the voltage gated calcium channel. So similarly, like the cancers in the lungs, particularly, especially the small cell carcinoma of the lung, they produce various substances. Like one of them you might have heard about, PTHRP, right, which stands for parathormone related peptide. So this is produced by the cancer cells. And as the name says, it behaves like parathormone. So this will go and stimulate the osteoclasts in the bone and increase the serum calcium levels, leading to hypercalcemia and all the consequences of hypercalcemia, like constipation, abdominal pain, renal stones, renal failure, or pancreatitis, all those consequences. ऐसा क्यों हो रहा है? Because not because of the problem of your parathyroid gland. Something similar to parathyroid hormone is being produced by the cancer cells. So here in Lambotatum, antibodies are produced by the cancer cells, which are blocking the voltage gated calcium channels. So today that's it, guys. So next class we will talk about the JB syndrome. As I told you, small homework, make a list of drugs that are approved in last 5 to 6 years for the management of Lambotatum myasthenia. I'll see you in the next class.